Good morning, everyone, and welcome to the Women's Society of Washington University's October lecture, the second in our 22-23 series, entitled From Research to Impact in Public Health, Translating What We Know into Action. I'm Angie Bernardi. I'm the president of the Women's Society of Washington University, and I want to thank you all for coming here today, both in person, especially due to the parking constraints, and live stream. We know that we have some people out there watching us. For more than 55 years, the Women's Society has sponsored student initiatives, including the Elizabeth Gray Danforth Scholarship, which provides 2 full-year tuition scholarships for St. Louis Community College students. We're proud partners in supporting and bringing to life Chancellor Martin's vision for Washington University to be in St. Louis and also for St. Louis. We're a group of volunteers of all ages and backgrounds who are interested in supporting the university and appreciate the valuable asset that it is to our community. The Women's Society also oversees the Bare Necessities Shop, which is located on the South 40. You can visit it in person or online, and it features unique WashU logo wear and clothing that can't be found anywhere else on campus. We also sell necessities for our students, including supplies, balloons, and birthday cakes. And all of those proceeds also support our scholarships. So please remember to stop by there. Many of you are members of our Women's Society, but for those of you who are not, I don't want to miss the opportunity to invite you to join us. And that way you won't miss any of our lectures throughout the year. Of course, especially today, featuring our prominent faculty from the medical school. We have new membership forms available online. And also we have a QR code at the desk, and I want to thank Blair and Judy and Aaron for helping us organize everything today. The Women's Society was created to bring the community to the university, so thanks for being here today. I want to welcome you one more time and hope you enjoy the program. Now it's my pleasure to turn things over to Aixa Martinez, who's the chair of our education committee. I'm grateful for her leadership and also the work of the entire committee in putting together this amazing lecture series this year. Welcome, Aixa.
Thank you, Angie. And good morning to all of you joining us today. I am Aixa Martinez, and I'm pleased to introduce today's speakers, Bill Powderly and Karen Joynt Maddox. Dr. William Powderly is the J. William Campbell Professor of Medicine, the Associate Dean for Clinical and Translational Sciences, and the Larry J. Shapiro Director of the Institute for Public Health at Washington University in St. Louis. He is also the Director of the Institute for Clinical and Translational Sciences and co-director of the Division of Infectious Diseases at the Washington University School of Medicine. From 2005 to 2012, he was Dean of Medicine and head of the School of Medicine at University College Dublin in Ireland. Powderly has been actively involved in HIV-related clinical research for 30 years. He has been a member of numerous advisory groups on HIV and infectious diseases for the National Institutes of Health, the U.S. Centers for Disease Control and Prevention, the Canadian Institute for Health Research, and the European Medicines Agency. He is the author of over 400 original manuscripts, reviews, and book chapters. As director of the Institute for Public Health, Powderly has translated scientific advances to a wider population to improve public health. Under his direction, the Institute has focused on implementation science, community partnerships, economic and policy research, and global health to broaden the impact of discovery science and address disparities in health outcomes. Powderly is a fellow of the Royal College of Physicians in Ireland, the Royal College of Physicians London, and the American Association for the Advancement of Science, and is a former president of the Infectious Diseases Society of America. Dr. Karen Joynt Maddox is a practicing cardiologist at Barnes-Jewish Hospital and associate professor with tenure at Washington University School of Medicine and Washington University's Brown School of Social Work. She is director of the Center for Health Services and Policy Research at Washington University School of Medicine and co-director of the Center for Health Economics and Policy at Washington University's Institute for Public Health. She served from 2014 to 2016 as senior advisor in the Office of Health Policy in the United States Department of Health and Human Services. Dr. Joynt Maddox received her AB in public policy from the Woodrow Wilson School at Princeton University and her MD from Duke University School of Medicine. She trained in internal medicine at Duke University Medical Center and then in cardiovascular medicine at Brigham and Women's Hospital. She's also completed a research fellowship in health policy at the Harvard School of Public Health, from which she received her MPH. She has three main areas of research, all focused on health equity. The first area of work is in quantifying inequities in healthcare quality and outcomes for vulnerable populations, including racial and ethnic minorities, individuals living in poverty, individuals with disabilities, frail elders, and those in rural areas. The second area of work is in evaluating the impact of federal and state health policies, such as Medicare value-based and alternative payment models and state Medicaid expansions on quality, outcomes, and costs, with a particular focus on their effect on racial and socioeconomic inequities. The third area of work regards the ways in which race and social risk are used in risk prediction models for clinical events across a range of conditions, and how these might lead to over or underestimates of risk and therefore inaccurate clinical interventions, quality measurement, and payment. She has authored over 250 peer-reviewed publications and has received federal and foundation grants focused on issues in health policy. She serves as the associate editor for health policy at the Journal of the American Medical Association and is a member of committees related to quality measurement and payment reform at the National Quality Forum, American College of Cardiology, and American Heart Association. Please join me in welcoming Dr. Powderly and Dr. Joynt Maddox. We are grateful to have them with us today.
Good morning, and thank you for the invitation. It's a pleasure to be here and to speak to the Women's Society. I think I last spoke to the Women's Society about 6 years ago when we were talking about global health. And since then, we've had a major global health event that all of you are unfortunately very familiar with. So I'm going to talk a little bit about what we've learned from COVID and what that means for public health, both here in the United States and globally. So first of all, this epidemic has not gone away. We're still in the midst of ongoing spread of this virus. But this is an interesting analysis because this is actually conducted by The Economist. I think many of you may be familiar with that magazine that looks at what has been officially reported worldwide. It's about 6.5 million deaths. And what they believe is the actual mortality from COVID, reflecting the fact that in many countries, incidence and mortality is grossly underreported. And they look then at deaths that are occurring above and beyond what should have happened if there had been no pandemic. And the estimate there, that conservative estimate by The Economist, is that approximately 23 million people worldwide have died thus far as a result of, directly or indirectly, of COVID. So it is undoubtedly a major public health issue. And it is, as Ross Brownson, my colleague and professor of public health, Lipstein Professor of Public Health at the Brown School, eloquently put it at the beginning of, shortly into the epidemic, a significant public health failure. And why would you say that? Well, if you think about what public health ought to be doing, it is assessing a problem, putting in preventive strategies, and ensuring that to the public that they are protected. That's what public health has done for hundreds of years or 150 years in very simple ways. Most of you have gone to a restaurant in the last month or so. Well, because of public health, you have an assumption that the food you're eating is safe, the preparation of that food is safe, and the water you drink is safe. That's a fundamental tenet of public health. Yet in terms of all of the factors that go into protecting the community, the virus appeared, but what happened as a consequence is a failure of public health. And we have to think about why that is and what we can do in the future to prevent that. So we did not have insufficient preparedness. And it's really ironic that in 2019, there was an official analysis of the world's ability to respond to a new pandemic. And that analysis said the United States was the best prepared country in the world. And the second best prepared country in the world was the UK. Our problems were then complicated by long-standing and worsening health inequalities, and Karen will talk a little bit about that. And as we all know, the rapid spread of misinformation. And I'll come back to that a little later. So where are we now? The good news is that we got a vaccine incredibly quickly, and that was remarkable. It's a remarkable tribute to the multidisciplinary science, people coming together and rapidly deploying a vaccine. And it works. It really is very effective in preventing death. It doesn't prevent disease to the same extent, but it absolutely prevents death. The bad news, particularly in the United States, is a significant number of people are not getting vaccinated, and particularly are not getting boosted. And that remains an important issue. We are continuing to see ongoing spread. 400 people are dying every week of COVID in the United States. This has not gone away. We continue to see hospitalization. The numbers in our hospital at Barnes have not gone down since May. We have the same number of people in the hospital coming in every day with COVID, the same number of people in our ICUs, the same number of people being ventilated. So on average, we have 50 patients in Barnes Hospital every day with COVID. This virus will continue to be a threat because it has the ability to change. And we don't know what the direction of that change will be, but I am optimistic that we will have tools to deal with it more effectively, both in terms of prevention with vaccines and treatment as treatment has been evolving. So it will become more like influenza, more like other serious viral infections that are a threat to us, but ones that we can manage. That is our hope, but it is not certain. So vaccination does help, as I said. You know, this is just data showing that if you are vaccinated, you're less likely to be infected, although you still can become infected, and you're significantly less likely to have serious illness, be hospitalized, or die as a result of virus. We don't know the long-term impact. This is data that was published about a year ago from one of our researchers in public health, looking at a large database from the VA hospital systems that really suggested that long COVID, or the long-term consequences of COVID, are quite significant, may affect as many as 10% of people who have had COVID in some way, and that there will be a significant healthcare morbidity and cost from this virus that we have yet to completely understand and figure out. And so there will be many patients who will continue to have the consequences of this virus well after the infection. So one of the things that is worth considering is the challenge that we had in this country. And that is, we have been proud for 200 years of US exceptionalism, about the US not accepting what is the norm. It has driven advances, both technological, economic, and social in this country. But in this particular case, US exceptionalism actually led to harm. Both the public health guidelines that were introduced at the beginning of the epidemic were, by a segment of the population, vehemently and sometimes violently rejected. There's strong evidence of drugs that work, drugs that don't work. However, much attention was given to drugs that are completely useless, that were touted by non-medical experts. And we have a very effective vaccine. And yet, in spite of that, and in spite of the fact that vaccines have been the key to controlling viral infections for 120 years, a significant portion of the population rejected vaccines. And this is ironic because the greatest public health advances in the 20th century, why humans are living longer now than they were in 1900, as a result of three things. And none of them are medical technologies, better treatment. They are clean water, safe food, and vaccination against childhood illnesses that killed millions before we had vaccines. So this is data, for example, in terms of the data that provided from our own Institute for Public Health, doing a counterfactual analysis, which basically said, had we delayed the masking mandate in St. Louis City and County, how many people would have died? And the answer is very clear. Every week delay would have led to more deaths, and a month's delay would have led to probably about 2,000 extra deaths in our community. So this is just to put it in a worldwide perspective. The total number of deaths in the United States has been over 1 million. If you look at deaths per 100,000, you can compare countries. And with the exception of the United Kingdom, which everybody accepts was completely flawed in its response in the initial wave because from a lack of government action, we really don't compare well to our peers. Unless you believe Brazil is a peer. And unfortunately, it was getting worse. So if you look at across the board, the United States looked a little worse than most of other countries, but other countries actually, when vaccination arose, other countries had strategies that rapidly deployed vaccine to vulnerable people, and we didn't. So we have this situation where only 30% of the population in the United States is fully has been boosted. Only 68% of the population is fully vaccinated. That is, has had at least 2 doses, and 80% are vaccinated. And you can see where we are in relation to countries we clearly would regard as peers. We are at the bottom of the list. And that is the vulnerability we continue to face, much more than other countries, as we come into winter and the likelihood of COVID spreading again. So let me turn now to some of the broader issues around public health. So this is a graph of life expectancy in the 20th century. And you can see that life expectancy in the 20th century really improved in the United States from an average survival, a median survival of about 46 years at the beginning of the century to nearly 80 years by the end of the century. There was one blip. That blip was in 18, 19, 19, and it was the influenza epidemic, which worldwide killed at least 50 million people. So for the first time since that epidemic, influenza, life expectancy in the United States has dropped. And this is a consequence of COVID, almost entirely. And so we are now, for the first time in 120 years, on a downward slope, something we ought to be as a society talking more about. But we don't. We're having a little bit of a technical slowing here, so we'll have to bear with us. The other thing that COVID showed us is widespread health inequity. We saw at the beginning of this epidemic many, many more cases of COVID and much more morbidity and death in minority populations. And for many reasons. Part of it was we know that COVID is more severe if people have what we call comorbid conditions. That is, they have diabetes, they have hypertension, they have heart disease or severe lung disease. And these are more likely in minority populations. But there are also significant issues around access to care that are critically important. And Karen will talk a little bit more about this whole issue of how we address inequity in our healthcare system. So, what do we know? 2 years later, 2 years after nearly 3 years after this epidemic, we know that we need a better strategy. That if we want to treat this infection and continue to manage this infection or address other future microbial pathogens, we need a national strategy. One of the problems the United States has is it doesn't have a public health strategy for the country because public health is decentralized, and therefore we have actually 50 public health strategies in the United States. But we also need to center our reinvestment in public health on social justice, recognizing the fact that we need to make this equitable for all our citizens. And we need to think about what are the skill sets that public health practitioners in the future are going to need to respond to this or similar epidemics. And that really is a challenge not only for us as a society, but for us as providers of education. So, in the midst of all of this, we had another virus epidemic. A new national public health emergency was declared by the CDC around monkeypox. Now, it's very different in terms of both its spread and its severity. But as of August, or as of Wednesday, we had 26 million cases, 26,000 cases in the United States, and across most of the country. So, I'm a professor in the medical school. How would I grade the response of the United States 2 years after we had a pandemic, so we knew all the things that we should have been able to do, to monkeypox? Well, as a long-term epidemic, I would essentially give the United States an F. And this is even worse than you think. Because when COVID came along, it was a new virus. We knew nothing about it. We didn't have a vaccine. We didn't have treatment. We didn't know how it was spread. So we were, for the first 6 months, really trying to figure it out. With monkeypox, we knew what the virus was. We knew how it was spread. We actually had a test available. There was a vaccine available. There was treatment available. And guess what? Even though it was happening in Europe 2 or 3 months before it came to the United States, nobody paid attention because that's somewhere else. That's over there. We couldn't gather epidemiological data because we have 50 healthcare systems. Some of them are linked into the CDC through electronic reporting. Some still send in written reports by fax to the CDC. The CDC, once again, although it had a test, didn't make that test widely available through commercial labs for about a month. Everything had to be done through the CDC, which led to delays. We had a vaccine. We actually had the vaccine. Monkeypox is similar to smallpox. And because of the fact that we were worried and had been worried about smallpox as a bioterrorism weapon, we had actually stockpiled 20 million doses of smallpox vaccine, which could have worked for the monkeypox. But it had expired and somebody made a decision not to renew the license. So we didn't have the supply immediately. Well, we did, but we didn't have a lot of it. And then it took, just so you know, it then took about a month to actually negotiate a new contract with the manufacturers in Denmark, even though we were in the middle of an emergency. We couldn't make it up. And then finally, we have a drug that actually is very effective for patients, but it's only available through the CDC. It requires a lot of paperwork that most physicians won't do, because to treat a patient required you to dedicate 3 hours of time to fill out the paperwork the CDC required. And it took about 3 or 4 days before you could get the drug that way. Now, we set up a mechanism where we could provide it more effectively and efficiently at WashU, but that was because we decided to go ahead and do it. And finally, even though we knew that this virus affected gay men, and particularly African American gay men, did we respond to target the right population? No. In New York, which had the largest outbreak initially, the vaccine was made available fairly quickly. 80% of cases were occurring in Black gay men. 80% of the vaccines went to white men. So to do what we need to do is a multifactorial issue. We need, first of all, we need leadership. We need leadership at multiple levels. But we particularly need political leadership. We need political leadership to say that public health is important and it needs to be invested in. It's an infrastructure no different than our roads, our water supply, our energy supply, and it needs that level of investment. If we don't do that, there will be another epidemic. I can guarantee you, as an infectious disease specialist, we will have another viral epidemic. I hope it's not in my lifetime, but we will have. We need to allocate our resources more effectively. And that's a very important issue as we think about it in terms of a place like Washington University, where we have one of the great medical schools in the country, if not in the world. That medicine and public health are intertwined and interconnected. That as we think about the advances in medicine and the things that we can do and the research that we do, it can't be just for the privileged and those who can afford it. It has to be for everybody, which means we have to address the public health and population needs of our communities. We need to reinvent our public health systems. We need to think about what we actually want in the United States, and we need to particularly modernize them using the fact that some states are still sending their data by fax just says it all. And finally, we need much better communication skills. We need to teach people communication skills. Scientists need to learn how to communicate and communicate in a better way. The amount of misinformation, ignorance, and frankly, untruth that is available now, so people cannot figure out what is right and what is wrong, is a major threat to the health of all of us. So what does it mean for us at Washington University? I think one of the things that is very clear is that there's more interest among our students in public health than there has been for a lot of time. And even if you think beyond this epidemic and think about what are the challenges that face us as a society in the 21st century. Issues like climate change, energy supply, the potential for future pandemics, environmental change and environmental degradation. All of these have tremendous public health implications. And so we need to use the fact that we are one of the country's great universities to build on that foundation and to put public health as part of our strategy for the 21st century. And the creation of a School of Public Health is one of those pillars that we will be going forward with in the next few years. So I will stop there. I'll hand it over to Karen and then we can take questions.
All right. Good morning, everyone. It's an honor to be here with all of you. And Bill is always a tough act to follow, but I will do my best to take us into a discussion of some of the other elements of public health that Bill sort of alluded to at the end of his comment. And then we'll hopefully be able to tie it all together with some questions. So as Bill alluded to, we know that there are profound and persistent health inequities based on a number of factors. So here we have data based on race. I guess I can travel with this thing. So you can see that we've had stagnating progress in equity and actually in mortality overall. So here we're looking at cardiovascular mortality for women and men broken down by race. And you can see after progress both in decreasing mortality overall and actually to some degree in closing the gap, we really haven't made much progress in the last decade or so in men or in women. And you can see based on poverty, something quite similar. This is work based on Medicare beneficiaries looking at annual mortality. And these are modeled numbers, so they aren't quite as flat as we made them look, but you can see about a twofold difference in annual mortality rate among Medicare beneficiaries based simply on whether or not they live in poverty, accounting for differences in chronic comorbidities. And we also know that one of the most important emerging areas of inequity is actually based on geography in a different way, based on rurality. So you can see that through the mid-80s, rural and urban death rates were about the same. And frankly, as progress has occurred in modern medicine and in public health, some of the areas that have been most deeply left behind have been rural. And you can see a stagnation here in the improvement in mortality, and now about a 20% disparity in overall mortality rates for rural versus urban populations. And you can imagine that if you put these things together, if you overlay race and poverty and rurality, you have some of the most deeply disadvantaged and vulnerable communities in the country. So what underlies these differences? We're scientists here, and so we try to come up with what are the things that drive these patterns that we see. I'm a cardiologist. We spend a lot of time talking about diet and exercise. We talk about tobacco use. And now we understand that things like stress matter, inflammation matters, environmental exposures matter. And as I've mentioned, we know that poverty and lack of education matter. As Bill referred to, we know that access matters. So do you have access to primary care, to specialty care, to quaternary care? And that's across the life course. Where you have access as a child drives a lot of your future health outcomes. But I would argue that what underlies most of these are fundamental structural inequities. No children are born into an area wanting to end up with chronic disease or poor access to education. And these are things that develop, again, over the life course as a result of the context in which people grow up. As a result, I would argue that health inequities are a policy problem and fundamentally a public health problem. They're reflective of systemic, broad, and longstanding issues, and with absolutely all due respect to the discovery taking place here and on the medical campus, clinician will, or the invention of a new drug, or the invention of a new device, or the invention of a new surgical technique, or a new imaging modality is not going to change these inequities. It's not going to fundamentally make us healthier. We want all of those discoveries, But we want people to have the opportunity to access all of those discoveries and not be stopped much too soon for other reasons. And so we have to structurally undo what was structurally done. We need policy and public health thinking to combat these major problems. So I'm going to talk about 3 key areas of policy that impact health. And these are coverage and access policy, payment and care delivery policy, and social and economic policy. And you can think of public health policy as sort of umbrella over all of these terms. They're sort of broken down more by how they're controlled in government, frankly, than they're really disconnected from each other. But we'll talk through some of the ones that impact all of our health. So we'll start with coverage and access policy. We know that minority, low income, and rural communities lack coverage, so insurance coverage, and lack access to care. So this is data looking at health insurance coverage starting around 2000 and going out to 2020. In the tan line is Hispanic individuals, in the orange line, Black individuals, and in the blue line, white individuals. And they're broken down by sex and by age. So this is 45 to 54, 55 to 64, and 65 or older. And there's so much information on this one slide. I have a lot of graphs in this talk because I really love the data, but there's so much information in this one slide. So for one thing, you can see that the inequities in insurance coverage are massive. If you look at the men aged 45 to 54, you have 30% of Hispanic men with no insurance coverage. You can see if you get out to the 65 and older, people love their Medicare. We have very few inequities in coverage. Some of the ones that exist are actually in part because you need to work for a certain number of years in the US to qualify for Medicare. So not everyone qualifies, particularly older immigrants, but very, very minor inequities here compared to here. The other thing you can certainly see is a giant drop in the uninsurance rate, or a huge gain in insurance coverage, and that was the Affordable Care Act. Now, about 2/3 of that gain was Medicaid, so people who were receiving Medicaid coverage through the states, and about 1/3 of it was from the exchanges, or the Obamacare, which was essentially created a market on which people could go buy insurance. Very, very difficult before the ACA to do that if you're trying to buy insurance on your own. Obamacare basically just created a market into which you could join to be able to buy your insurance. So we see a huge drop in the uninsurance rate. And while there are still important inequities, a significant narrowing in those inequities during that time. And why does that matter? So Medicaid is an equity enhancing policy. It is one of the strongest equity enhancing policies that we have. There's unequivocal evidence for financial protection of individuals, which makes sense, and actually of hospitals. So hospitals located in states with Medicaid expansion were less likely to close, preserving access to people, whether or not they were on Medicaid. We know there's strong evidence for Medicaid's association with better access to primary care, more ambulatory care visits, more use of prescription medications, better adherence, more access to preventive care, all the things that you would want for a healthy population. There's moderate evidence for better self-reported health, both physical and mental, and actually the mental health benefits are immediate. It's not just actually treating depression and anxiety, it's actually taking away the toxic stress of knowing that you are not covered if something catastrophic happens to you. There's mixed evidence for utilization, and some people have argued this is, Medicaid is worse than nothing because emergency department utilization goes up. It's because people come in when they're sick. We want people to use healthcare if they have coverage. We want them to use the right kind, and we prefer that not necessarily be through the emergency department, but if someone needs healthcare and they come to get healthcare, that is a win. And we do see utilization go up, especially immediately after someone gets coverage because they get their needs met. There's actually growing evidence for lower mortality, including infant mortality, which is arguably the most important mortality we could try to address with a policy, but also cardiovascular mortality and cancer mortality. And the impacts are largest for those from racial or ethnic minority groups and in rural areas, exactly the people where we have failed for so long. So where do we stand with Medicaid expansion? We can at least finally color Missouri in blue. I can say as a treating physician, being able to discharge people who now have coverage has been, it's hugely different in the hospital. This is every day affecting our patients. You can see there's still a geographic pattern to where Medicaid has not been expanded. And so uninsurance rates range vastly across the country, but Missouri has expanded, and we have been expanding more quickly for two interesting reasons. So the first, so this year you can obviously see the curve starts to go up, right? This is Medicaid enrollment. This is not Medicaid expansion. This is the pandemic. So one of the rules under the public health emergency was that you could not kick people off Medicaid. States are excellent at kicking people off Medicaid. You have to get a packet in the mail and it's 74 pages and you have to fill it out and you have to validate your employment or lack thereof. And that's how they get people off the rolls. You couldn't do that during the public health emergency. And so what happened was that our overall enrollment in Medicaid climbed from around 900,000 up to more like 1.4 million. This purple triangle right here is what we call the adult expansion group. People who are not previously eligible for Medicaid who now have coverage. And so we're seeing that group grow. The big question on everyone's mind for many policy reasons is what will happen when the public health emergency ends? And should we end some of these policies that have proven so beneficial that were sort of side effects of COVID? Okay. So move on then to the payment and care delivery policy. So we know that there's poor quality and outcomes in healthcare, at least more poor than they should be, and that that's worse in under-resourced areas. Why? We know that outcomes are worse at Safenet hospitals, at rural hospitals for a number of reasons. They have fewer resources, they have sicker patients, they have more socially complex patients, they have worse and scarcer outpatient care. It's also harder to attract and retain staff. Rural areas are just struggling incredibly with trying to have enough nurses and pharmacists and EMTs and all the parts of the healthcare machinery. It's tougher working conditions, there's less ancillary support, and sometimes it's lower quality of care, in part related to all of these reasons. But what the government has done so far to try to make this better is something called value-based payment. So one example of that is the Hospital Readmissions Reduction Program, which is a penalty program. They evaluate hospitals on readmission rates, so what percent of people come back within 30 days of discharge, and then penalize hospitals that do poorly. And the program is currently penalizing 80% of US hospitals. Now, these are the local penalties, and they'd range from negligible, although maybe a hospital administrator wouldn't find any of these negligible, but to what I think you could fairly call major. So you can see Christian Hospital in particular has had penalties of up to 2%. That means every bill that they send to Medicare comes back paid at 98% of what they billed. Now, you can imagine a quality improvement program for education that goes like that. Let's find the schools in town where the first graders are reading at the lowest level and take away 2% of their money. That doesn't seem like a terrific quality improvement program, right? It seems like a punitive program, which we know from many, many behavioral scientists is not the way you actually improve quality and outcomes, yet that has been the federal government's main approach to improve quality. And it hasn't worked. So while readmissions have gone down, total hospital revisits have gone up. Because when someone comes back to the hospital within that magical 30 days and hospitals are worried about being penalized, they put them on observation status, or they send them home from the emergency department. It's not reduced inequities in readmissions either. So we know that Black patients are more likely to be readmitted than white patients. And if you look overall, or at low performing hospitals where the gaps actually widened, or at high performing hospitals where the gap didn't close, there's no evidence that this policy has actually been beneficial in improving the things that we want to improve most. Perhaps most concerning, there's actually a signal that mortality has gone up, and it's been among patients who were not readmitted. So if you come back to the hospital is on the hook for that readmission. They can't change it because readmission is fundamentally about what happens to you contextually outside the hospital in the vast majority of cases. About 10% are probably preventable by hospital behavior, the remaining 90% are not. And we send you home because we're worried about that penalty. There is potentially, for heart failure at least, a signal that mortality has gone up. We also know that these programs have taken money away from the hospitals that need it most. So large hospitals, teaching hospitals, and safety net hospitals were the most likely to be penalized in the program's first year. And if you play that out across all of the programs that Medicare does like this, we now have them 3 programs in the hospital, 1 in the outpatient setting, 1 in dialysis facilities. We've got a home health one, we've got a nursing home one. They all show the same pattern. Safety net hospitals markedly more likely to be penalized than non-safety net hospitals. That problem is compounded in the outpatient setting because our outpatient practices are so much more segregated than hospitals. And money is literally moving from the poor to pay the rich to reward them for better quality, as opposed to going to actually try to reduce the underlying inequities. I told you there'd be a lot of graphs. That's kind of my thing. But you can also see that these decisions have had significant racial equity implications. So even controlling for poverty, we know that practices that serve a high proportion of Black patients are more likely to receive penalties in these programs, and hospitals that serve a high proportion of Black patients are more likely to receive penalties in these hospitals. Again, with no evidence that the penalties have actually driven improvements for the people about whom we worry. Now, there has been some progress, and have a slightly positive note about this, which is part of why this research is important. So the policymakers that made these programs didn't make it to hurt people. They made them to help people. It makes sense, right? You're going to hold people accountable for quality, and quality is going to get better. And it turns out to be not that simple. It's not the wrong idea. It wasn't the wrong intent. It was bad execution. And we don't really research the implementation of any of these things, which is another problem. But people actually did respond to this research. So when I was in Washington, I worked on this fix, which eventually went into effect through the 21st Century Cures Act, and it reduced penalties to the safety net by $22 million, simply by making hospitals compete against their peers. So the program was reorganized such that the richest hospitals competed with each other, the poorest hospitals competed with each other, and everywhere in between. So you needed to do well, but only compared to hospitals that treated a similarly complex group of patients, sort of a combination of medical and social complexity. As you can see here, modeled out $22 million less in penalties to the safety net, picked up by, I still don't think this is a good plan, but at least picked up by hospitals that were serving wealthier populations and spread the pain, so to speak. Again, still don't think it's necessarily the best behavioral program, but at least changing it to recognize that we need to have hospitals competing against their peers changed vastly the financial implications. More recently, under this administration, there's been a real move toward thinking about payment policy, not just about how it can avoid hurting people, but how you could actually leverage all of that money, all of that expertise, and all of that power that sits in the medical establishment to make people healthier. This program will launch in January. ACO REACH, it's an accountable care organization program where organizations have to have an equity plan. They have to actually measure things by race. They have to actually think about poverty. And they're going to get data feedback on how they're doing for key subpopulations. This has never been done before in Medicare payment policy. And so it's been a long time coming, perhaps a little overdue, but at least we're getting there. And we hope that this is the kind of move to think about how we can leverage policy to improve equity, as opposed to have it be a detraction. So finally, social and economic policy. Now, if we really want to make health more equitable, we have to invest in at-risk communities. We can do all the hospital planning we want. We can give people vaccines. You can do all of the things. And if you don't fix the underlying problems, you'll never address the inequities as well as you could. Health is a public good, right? It's not just infectious disease. Infectious disease is a terrific example of why health is a public good. But people's ability to reach their full potential makes us all better. We are all better when we are all healthy. And there is both a moral and economic imperative to thinking about health collectively. The problems that we see in health are not accidents, and structural problems won't go away without structural changes. The system achieves exactly what it is designed to do. If you change the system, it will achieve something different. That means, in addition to intentionally changing healthcare access, we have to consider our role as a medical community and a public health community to change economic opportunity, to train clinicians from historically excluded groups who have been prevented from pursuing careers in medicine, to train clinicians from rural areas who are much more likely to want to go take care of patients in rural areas. These are choices we can make And as a public health community, we can both advocate for it and also create the evidence to demonstrate why it's important and how to do it right. So in summary, health policy is a crucial tool to improve health outcomes and reduce or ultimately eliminate health inequities. What was structurally done needs to be structurally undone. And in policy, though the time frame is long, the opportunity for impact is large. I think that goes for what I've talked about and also all of the elements that Bill talked about in terms of a functional public health system. So I will end here and we will look forward to your questions. Now for the fireside chat.
Anybody got anything?
There's one in the middle.
Good.
Oh, it's me.
Yeah.
All right. I was alive when everybody had polio injections and under the tongue injections, sugar cube ones. And those were all done through the schools. And they would say on Thursday, every elementary school in the whole city was giving out the medicine. And that worked. Everybody showed up. And we didn't have the politicized, you were a Democrat, you took it, and if you were a Republican, you didn't because they were trying to hurt you. That never crossed anybody's mind, and it still shouldn't. So what could we have done better other than go back to the old program of using the schools?
So, I mean, that's a great question. One of the things I think has been challenging in the last 20 years is there has been a rise in what we call anti-vax sentiment, not just around COVID, but even before COVID. And part of it is the loss of community memory. So I was born in the mid-50s. I had my polio vaccine at the age of 6. I remember the sugar cubes. But you recall that the mothers and grandmothers in the 1940s and 50s feared polio. Kids did not go to public swimming pools because of the consequence of polio. The images of the children in the iron lungs was in every mother's mind. So there was no question as a society to say, this is a public good. We have to get our children vaccinated. And their mothers knew about diphtheria. They knew about the impact of measles, the impact of German measles, and the consequences of that for pregnancy. And so as a society, we recognized the value of vaccination. And then those grandmothers passed on, those mothers got older, and their children and grandchildren knew nothing about the consequences of these childhood viruses. They'd never seen them. They'd never seen them. And prominent people then said, well, vaccines are dangerous. And it became part of this urban myth that was being spread by influencers or whatever you want to call them. And that's the environment we got when we had COVID. And you had people whose motivation I will never understand, telling falsehoods on social media that people latched onto. The fact that it became politicized is one of the worst things that has happened to us. And I can't explain it. It's extraordinarily unfortunate because the reality is public health is not a political issue, and the COVID virus couldn't care less whether you're a Democrat or a Republican.
Well, neither does cardiovascular disease, right? And if you look at actually mortality in counties based on their political leanings over the last few elections, you see a significant split in cancer mortality, cardiovascular mortality, even prior to COVID. So we had already sort of sowed the seeds of this disparate approach to public health. And I think just sort of the collective good versus the sort of individual right. And states have disinvested. So at the state level, there's huge disinvestment in public health. And consequently, you throw a pandemic on top of that, and you have sort of the perfect storm of already having hollowed out infrastructure that was at least associated with various sort of political leanings. I don't know what exactly the solution is, other than perhaps more of a national identity around public health to try to depoliticize it to some degree, to sort of build in an infrastructure that can't be politically manipulated. But I'm not sure how to get to that exactly. I don't think so.
Sorry. Thank you and thank you. Good morning again. I think your research is wonderful. I thank you for presenting it to us today, but I do have a concern. You found disparities between the races. What is being done to combat some of those things that are happening between the Black race? Are there programs being set up where this could be curtailed at this moment, or what?
I think it's a complicated question with a complicated answer. I think at every level, there are efforts being made. I think the efforts have previously been obviously entirely inadequate. I think there's been a lot too much top-down driven documentation of inequity and not enough community-driven solutions to try to reduce inequities. I know that thinking about the ways to make a community healthier can't come from, changing a Medicare payment policy. It comes from fundamentally thinking about ways to make a community healthier, and people in a community can tell you how to make that community healthier. But it also requires sort of dismantling some of the things that have made communities unhealthy to begin with. So in both cases, I think there has been a shift, at least over the last 5 years or so, certainly driven in part by a broader recognition of the role of racism in a lot of the stuff around both George Floyd and COVID sort of coinciding. I think we're still way, way behind, but I do think that the solutions being grounded in community needs and community knowledge, and then driven by a real shift in resources on the policy level, some progress has been made, but not nearly enough.
What I would add is, I think the first and most important step is to actually recognize it, collect the data, and talk about it, and actually make it a priority. Karen talked about with Medicare now, hospitals are going to be required to have an equity plan, and I think if you do even think about things locally, by collecting the data and saying, we were not, when we first deployed vaccines, and we deployed vaccines much better in West County than we did in North County. Why? Well, we relied on people using the internet to register. If you don't have access to the internet, and you're much less likely if you're poor to have reliable internet access, then even if you want the vaccine, you're creating a barrier. So it's addressing it, understanding even simple fixes, and saying, we need to do that. We need to fix that right now. And then you can start to address it in a small way. But the biggest thing from a public policy perspective is saying, yes, we have a problem and we need to do something about it. Not just, it's going from just saying, oh, there are differences in outcomes across races and across ethnicity and rural versus urban. Okay, You've told us that. Now, what are you going to do about it? And that's the discourse that we have to have at every level, at hospital level, at system level, and ultimately at a political level. What are we going to do about it?
Thank you very much.
You mentioned something about the Medicare payment policy. Does that have a lot to do with how much the medical doctors who are the administrators of these hospitals will receive according by race and ethnic group, whether you're Hispanic or Black or you live in North County or in the city?
In terms of the
amount
hospital
of money.
administrators, or in terms of what the hospitals are
What the
paid?
hospitals will receive, yes.
So right now, hospitals are paid on a fee schedule from Medicare. So you say we have a heart failure patient, you get paid $9,000. We have a sepsis patient, you get paid $17,000. And it's basically the same across the country with adjustments for cost of living. So New York hospitals get paid more than Missouri hospitals. It's based on a sort of national cost of living, and it doesn't take any of those things into account. It will adjust payments based on various degrees of complexity. So if you're 85 and have a hip replacement, a hospital will get paid more than if you're 45 and have a hip replacement, because you're going to have a different set of comorbidities that sort of bump you into different levels. I think what the bigger problem is that the Medicaid payment rates are so low, and the burden on different hospitals to care for people who are not insured, and the programs to provide hospitals with resources to do that are so inadequate that hospitals are grossly differently resourced. So even though within Medicare, which is maybe 35% of most hospitals' book of business, you're getting a reasonable payment, hospitals for the remaining 65% of their patients are getting vastly different reimbursement. So hospitals are operating with just orders of magnitude different of resources. You can see it around St. Louis and anywhere around the country. So the solution, in part, in my opinion, is to fix Medicaid payment rates and to get the private insurers to also be on board with trying to think about ways to make things better, which right now they sort of operate in a different sphere, I suppose.
We have a question from online, and I think probably for time, this is where we'll end it for today. So thank you for your time. But you alluded to, or you very specifically mentioned, the decline in life expectancy. So the question was, what do we need to do? What can we do to get that life expectancy back up?
Well, that's a complex question, because the decline in life expectancy is has been driven by COVID. But it's not just the virus itself. Part of the, as I pointed out in the very first slide, The Economist has done a really interesting analysis of the consequences of COVID. And what their analysis would suggest is that about half the excess deaths are directly from the virus, but half of the excess deaths are because people are dying from things that could have been treated but weren't treated properly or well. So people didn't have, they didn't get as rapid access to heart care, to cancer care. They didn't have their cancer screening, their mammograms or whatever, cervical cancer screening, et cetera, were canceled because hospitals were overwhelmed, and so forth. And all of those. And so what is unclear is how long it will take the systems to recover. And when you have a system, as Karen described, that is already under enormous strain and is frankly inequitable, we don't know how quickly we can recover. So the consequences of this virus infection may actually be longer than the actual circulation of the virus. If I was able to predict the future, I probably wouldn't be a medical school professor. I'd have been retired by now. But I will just say that I think it is going to take us some time to get over the effects of this virus and get back on a different trajectory.
Agreed. I would just add one final thing. The other effect that we'll see in the long run is the mental health effects of COVID, which probably are years and years kind of ripple effect. And so if there's anything we can do societally around trying to sort of improve morale, right? I mean, I don't know what to call that exactly, but there is some value to morale and thinking about how to help us all move into a more optimistic state of being is actually going to be an important thing for life expectancy when you think about the longer term effects of mental health too.
Thank you, Dr. Powderly and Dr. Maddox. We do want to present you with a token of our appreciation, and we are grateful to you for sharing all this information. It gives us a lot to think about and a lot to share with others.
Thank you. That's lovely.
Thank you so much.
And I want to thank everyone for joining us and invite you to our next event, which will be November 15th, and it will be the Mosaic Whispers a cappella group. Should be a festive occasion for a lecture. It'll be in the evening, so please feel free to bring your guests and friends. And if you'd like to sign up, you can do it at our website online. And we also have our Composing a Life panel coming up on October 18th, if you'd like to join us for that right here. And also, please pick up your parking ticket on your way out. They wanted me to make sure to remind you. Thank you again. We really appreciate the information, and I hope you all have a wonderful day.
It was good talk,
Thank you.
really good talk.
I enjoyed yours.